Hello, everyone. I'm Carmen Pugliafito, and I'm here today with Professor Ninel Gregori of the Bascom Palmer Eye Institute of the University of Miami School of Medicine. Nell, welcome to Retina Synthesis.
Thank you. Thank you, Dr. Pugliafito, for having me on the air with you.
So you've done a lot of work on gene therapy for inherited retinal disorders. And can you just give us a definition of what the scope of this field is like today?
Sure. So with my wonderful colleagues, Byron Lamb and Janet Davis, we started on choroideremia back in 2014, I believe, or 2016. And that was really the first clinical trials that we did and learned how to do the procedure and developed the technique and started using OCT, intraoperative OCT, because it was such a tough disorder. And then we evolved onto other conditions, X-linked RP and other forms of RP. And what else did we do? Mainly those, and then it kind of evolves to Stargardt and optogenetics and you name it. So it's been really fun. And I could tell you that looking at clinicaltrials.gov, which I just actually did for a talk that I'm doing in Boston for Atlantic Coast Retina meeting, I could see that there are so many trials in various conditions, phase 1 and phase 2, and now we even have phase 3 clinical trials, such as those in X-linked retinitis pigmentosa. And I'm going to look at my notes so that I don't forget to tell you which other ones, but yeah, and ASH2A, RP with exon 13 mutation. So those are the phase 3 clinical trials, but there are so many phase 1 and 2 and phase 2 clinical trials, and conditions such as choroideremia, X-linked retinitis pigmentosa, X-linked retinoschisis, and in LCA types, in also Stargardt. Those are the optogenetic Stargardt and end-stage Stargardt and end-stage RP. So we certainly have so many conditions that are being studied in these trials, and hopefully we'll have a new medicine come out, not just RPE65 or Retigene Firovec that we have now, but perhaps we'll have others if these trials show safety and efficacy of these agents.
So what are the key steps in starting a successful program?
Well, I think it takes a team, definitely. The team should have a surgeon or two that are comfortable in doing subretinal, intravitreal, and now suprachoroidal injections. And it's not that difficult. We can be taught and we can be trained. It also takes a good surgical team. We have technicians and nurses that have been doing this with us for many years. And I know that if they are with me in the operating room, if I have any issues with instrumentation, they will get me through it. So they're very familiar with the procedure. It also takes close collaboration with the companies, with the sponsor. I really love when sponsors come to the surgeries and are there to suggest perhaps on how to proceed, because some surgical procedures are a bit tricky, and it's really good to have someone there from the company to guide you along. Sometimes that you need that. Clinical coordinators are just amazing and are a really important part of the team. So good technicians, just good infrastructure for all the testing that needs to be done for these patients. Mobility testing, you need to have a room. And we do have a room at Bascom Palmer where mobility testing is performed. So great photographer, great technician, clinical or study coordinator, and your OR team. It really makes the essence of it.
What's the average age of the patients enrolled in the trials?
Well, it depends on which disease and which trials, right? So Nina Barakal does children, and she's involved in clinical trials that are treating pediatric population. I'm involved with the adults mostly, although I have treated older children, 10 and above. So I would say that it depends on the disease. So in choroideremia, we had younger patients. They were in their 20s and 30s. In X-linked retinitis pigmentosa, we had younger patients. These were, again, in their 20s, because X-linked RP starts early in life. End stage conditions, trials of optogenetics and others, those are older patients in their 40s, 50s, and 60s. So it just depends, but it's a good spread of various ages.
What's the preoperative evaluation of the patients like?
Well, they have to be, of course, genetically tested to make sure that they qualify for the trial. And we have to make sure that the eye is healthy. We rule out things like cataracts and glaucoma, and make sure that the eye is healthy enough, that there's enough retina on the OCT that would have some viable cells that perhaps could benefit from the gene therapy that we are putting in the eye. So those are the clinical aspects that we'll look at. And then, of course, we want to make sure that the patient and the family are supportive of the whole process. They have to make sure that they come in and follow through with all the clinical and study visits. So, but I would say that it's a good discussion. I always explain to the patients and the family what's involved, the risks, and the risks are a bit unusual, I guess, because this is many of these trials are phase 1, 2, so we're just starting out. Inflammation, visual loss, could definitely occur. So I have to really make sure they understand that this is not a drug yet that we know that it will benefit them, but that's why we're doing the trial, and that's why we're doing the, giving them hope in the trial and hope for the patients to come.
Can you estimate the total number of patients that have been treated in your program to date?
So we published during the pandemic. I wrote with Janet a paper on our first 120 cases that we did, I would say, by 2020. Since then, we've done another probably, I would say, 30 cases I've done since then. So we are around 150, maybe 160 cases so far. And I would need to count, I guess, to be.
So that's a big program.
Yeah, no, we definitely, it was really interesting, Carmen, that when we started, this was such a new procedure, and we had to really figure out how to do it safely. I remember in the early days, we didn't even have a commercially available microinjector. So we had to use syringes that we had in clinic and special adapters to connect it to the vitrectomy machine, because of course the tubing that we use to inject gene therapy and BSS and all that connects to the FC function of the machine, and only the 10 cc syringe would connect to that because of the adapter that comes in the standard pack. So we had to be inventive and use special adapters, and we didn't even have many cannulas, subretinal cannulas. So then Med1 came through and made the microinjector that's now being used for majority of the trials, I would say. And the cannulas, and then the DORC came up with a nice extendable cannula that's really awesome to hold in your hand like a pen. So it makes it easier. So, and then of course the surgeons, we were all discussing, how do we do it safely? Do we start with a pre-bleb, BSS pre-bleb? Is it necessary? Of course, the amount of the drug that you get in many of these trials is so small that if you cannot raise the retina immediately, and I'm talking about subretinal cases, of course, then you could waste the drug. And so we decided initially, and it became sort of a uniform, very acceptable step, is to make that initial BSS pre-bleb and then inject the medication into it. So, but I remember the early discussions back in 2014, 15, 16 is when the surgeons were concerned about doing that. And, but by now, I think we're all convinced that pre-bleb is helpful in some cases. If you have a lot of drug, you don't need pre-bleb. Some IRDs are easier. There's less of adhesion between retina and the RPE, so it's easier to lift the retina in some conditions, and in others is very difficult. Choroideremia is being, I think, the most difficult condition that I worked with so far. So intraoperative OCT was an essential device. We acquired it at Bascom around 2015-16, and we started using it right away on choroideremia cases, because it was just impossible to know if you were suprachoroidal, if you were subretinal, sub-RPE. So that made it so much more definitive for us. Where were we, in which tissue plane were we? And so I don't think we could really have done that trial and done it well without intraoperative OCT. So that was a major, I think, breakthrough for gene therapy as a field in general.
What are the commonalities of the vitreous surgery?
Commonalities. So if you're talking about transvitreal subretinal injection, you're talking about, I assume, the vitrectomy that's required for eventually putting medication onto the retina. Well, the commonality is that the vitreous is quite abnormal in patients with IRD. And it was interesting to see that. And I think I learned a lot doing those cases. I learned that it's almost like peeling a membrane, really lifting the hyaloid in a lot of these IRD patients. So we had to stain. I like triamcinolone acetonide. I stained with that. We had to strip the hyaloid off the macula with either a scraper, like a finesse loop, or soft tip. And it requires a lot of work at times. So once you've done that, you have to be very careful in the periphery, because the vitreous is very adherent there as well. And even in older patients, even in 50s and 60-year-old patients. So one has to be really careful and perform limited vitrectomy. I don't lift the hyaloid all the way to the aura like you would in a normal case. I cut it down. If I see that it's adherent, doesn't want to come up, I don't force it, because you want to avoid iatrogenic breaks. And in these patients, the retina is very thin, and the laser might not take really around these breaks. So one has to be really careful in the periphery. So I think that's sort of a commonality, I think, that you're looking for in the IRD cases, perhaps.
So the modes of delivery are subretinal and suprachoroidal.
Right, and intravitreal. So subretinal could be done transvitreally, required where a vitrectomy is done first, or now Gyroscope Therapeutics has this Orbit device, which is a suprachoroidal approach to subretinal injection. So you don't need to do a vitrectomy. It's a cut down in the sclera. The microcannula is passed through suprachoroidal space, and then a microneedle penetrates the retina into subretinal space, and a bleb is delivered through suprachoroidal space. So it's interesting. They're doing clinical trials with it, so we'll see how that goes. Gyroscope works in dry AMD clinical trials. The suprachoroidal, I think, is the most recent really approach, where it's truly suprachoroidal delivery of gene therapy. You don't go through suprachoroidal space to get into subretinal space. You actually deliver gene therapy to suprachoroidal space. And that's being done by REGENXBIO in wet AMD. So they have clinical trials where they're actually delivering medication with Clearside Therapeutics has the suprachoroidal device, which is actually the same device that's now FDA approved for Xipere, the steroid, suprachoroidal steroid for uveitic macular edema. So it's the same device. And I've played with it, and it's seems to be easy to use. It's done through conjunctiva, so you don't need to take the patient to the operating room. You could actually do it in clinic. So that's and Peter Campochero and his group, his lab, they did a lot of work to show that in rats and in non-human primates, suprachoroidal delivery of the vector that the Regenxbio Bio uses, which is AAV8 viral vector, that it actually produces the same expression of the anti-VEGF protein in the retina, choroid, and RPE after suprachoroidal and after subretinal delivery. So it seems to work. It even goes a little further. It spreads out further than, at least in the animals, than if this drug is delivered subretinally. So that's an exciting new way to deliver gene therapy without having to do vitrectomy, and perhaps gene therapy will last longer. We don't know, right? And spread further, because of course the limitations of the bleb is that it's wonderful and beautiful bleb, but it's small, right? And if you want to treat a patient early on that still has a lot of viable retina, you want to deliver this medication to a wider area of the retina, not just a little bleb. So an intravitreal delivery is also being studied now in many trials. I mentioned initially, of course, the problem with intravitreal delivery was that the naturally occurring AAV vectors did not penetrate the retina. So if you put that medication into the eye, it only could transduce or affect the inner retina, right? The ganglion cells and the bipolar cells. And it didn't penetrate the retina to go to photoreceptors in RPE. That's why we started doing subretinal injections initially. Now, these vectors have been now modified, and there are these designer vectors that actually penetrate the retina. And so there are trials now, for choroideremia and RP and LCA, even melanomas. They're oncolytic viruses that are being delivered intravitreally. It's interesting. And optogenetics is also an intravitreal approach. Optogenetics, of course, is easy because you just need to deliver the virus to the inner retina. But in other conditions, the viruses actually penetrate the retina. And so, that could also be a very easy in clinic kind of approach to deliver gene therapy. And because it doesn't require surgery, you could deliver it perhaps multiple times. So, of course, the concern with intravitreal delivery is inflammation, right? You were putting a virus into the eye. So inflammation and hypotony. And, as you remember, in 2021, there was this case from Adverum diabetic retinopathy trial where there was a patient who unfortunately had inflammation and hypotony, and that trial was shut down in diabetic retinopathy. Their trial, though, with intravitreal medication for dry AMD is continuing, and it's continuing just fine. So we have to see how the results come out. But so those are the different approaches, and they have all their advantages and disadvantages, and we just have to see which medication and which disease will, do well with these as clinical trials go on. So very exciting to keep watching this.
So what clinical trials are most advanced in the field of inherited retinal disorders?
So I knew you were going to ask me this question, so I'm going to look at my cheat sheet. Well, phase 3 clinical trials, right? So that's kind of where we are. So once we get to phase 3, we're getting closer to FDA approval. So I'm going to tell you that the Leber hereditary optic neuropathy, there are several trials, phase 3, from Genzyme that actually showed really exciting data. And I know it's optic nerve, it's not the retina, but hey, it's pretty close to the retina. So I'm excited to see when this medication will be approved. It's for 11778 mutation, mitochondrial DNA mutation. So, what was exciting about that is that they injected one eye and they saw improvement in visual acuity in the second eye. in the contralateral eye. So then they said, how is this possible? So when they did non-human primate studies, they actually showed that the virus was able to get to the other eye and also into the lateral geniculate nucleus, not to the cortex. So, but it did spread. Isn't that interesting? So they actually failed to show a difference between treated and untreated eye because the stuff got into the other eye and both eyes improved. Now, how exciting is that? Now, when they did another trial, bilateral injections, they did show an improvement with bilateral injections beyond what they got from the contralateral spread. But so we'll see what the FDA decides with that. Okay, so that's that. And then ProQR is doing phase 2/3 in their OSH2A exon 13 mutation. And ProQR works with RNA antisense oligonucleotide. And so it's an intravitreal injection. And we have to see what happens with that. It modulates splicing. So essentially you eliminate exon 13 from the mRNA and you make a shorter but functional protein instead of having the protein be completely dysfunctional. So that's going on. X-linked retinitis pigmentosa, 2 companies, Mayra GTX has a phase 3 clinical trial, and AGTC has phase 2/3. Both work with RPGR gene in their viral construct. So those are the phase 3, and I know that probably tomorrow there will be another one that I'm not going to mention today, just because their companies are moving along, and more and more trials are popping up. But unfortunately, our phase 3 clinical trial with Biogen called STAR in choroideremia patients, we did a lot of patients for that trial at Bascom Palmer, and that trial failed. The primary outcome measure was set up at 3 lines of improvement, and that was it didn't happen. And then also the secondary outcomes, microperimetry, and others did not show a significant improvement after therapy. So, we learned a lot by doing those patients, but unfortunately, we don't have a drug now that's approved for choroideremia, because of the failure of that phase 3 trial. So, yeah, it's an exciting field, and I think we just have to keep working, because eventually we're going to have more drugs for patients that never had any treatment, never had any hope. So that's what makes me excited. Yeah.
So what about patients with autosomal recessive retinitis pigmentosa? Any hope for them?
So I don't have in mind, any trial that I could tell you. Although I know that antisense oligonucleotide and CRISPR, those are more LCA, and they are autosomal recessive, RP form. They are. So I know that these trials are out there, but I don't have any information about them to really tell you, because I haven't personally worked in it, and but I know LCA. Which is in the spectrum of autosomal recessive RP, is definitely being studied, and it's with intravitreal therapy and with subretinal. And I could tell you that unfortunately, the sepofarsen, right, from ProQR that was being studied for LCA10, which is CEP290 mutation, their phase 1/2 showed such promising results. And then when they went to phase 2, it didn't pan out. So they didn't show a significant improvement in that trial. It was actually phase 2/3 that they did. And that was with RNA antisense oligonucleotide for CEP290 LCA10. So you know, we'll see what happens next. But unfortunately, for at least for ProQR phase 2/3 trial, it didn't end up showing the same exciting results as phase 1/2 did.
So do you think someday that gene therapy will be a routine part of the ophthalmic armamentarium of therapy?
I think so. I think eventually that's what we'll be doing. And I think we'll be learning more and more genes that are responsible for glaucoma and for, you know, for even macular degeneration at some point. You know, the trials that Gyroscope is doing are interesting because they are doing genetic testing in these patients. And, you know, there's 2 trials, Explore and Horizon from Gyroscope. And in one of them, they're including patients with low systemic levels of complement factor I, which is, it inhibits the alternative complement pathway. So, and then the other trial is recruiting patients across the board, 100% of GA patients. So we'll see if indeed having, you know, this medication injected in an eye of a patient with low CFI, it would be maybe more efficacious than if your CFI was normal in the blood. So, or in the eye also. So it's interesting. So I think we're going to discover more mutations. I think genetic testing really is important these days so that patients know what mutations they have. They're not even called mutations anymore. They're called genetic variants just because we're all different. It's, you know, doesn't sound like, you know, you're a mutant or something. But in any case, I think we're going to discover more mutations. And yes, genetic testing is going to be a part of, and genetic therapy or gene therapy is going to be a part of ophthalmology. I just don't know in how many years, but probably not that far.
Well, great. Congratulations on this great program that you've been doing, and we look forward to following up.
Sounds great. Thanks so much for having me on your exciting program.